the system have both been kind of emerging as like the two personality factors that are more strongly associated with mortality risk.
I'd like to see some of the conscientiousness stuff because neuroticism has been around for ages as a predictor of mortality and morbidity over decades. But conscientiousness has often been one of those things that in the discussion section you're saying, gee, it seems like this really ought to work, but it didn't really pan out. So people are having better luck with it. Yeah, it should work because conscientious people would be more adherent to medical treatment regimes, presumably would pursue health behavior recommendations and stuff. So logically it should work, but at least until recently the evidence has been mixed. I mean, there's always been some people finding connections, but there's also been a lot of the studies where people are kind of scratching their heads saying it actually turned out to be either uncorrelated or even, in a few cases, I think even negatively related. There was a really nice, I've heard this stuff for years, there's a really nice summary of this on All Things Considered one evening last week. I think it was after class last week. It summarized the data on how more medical treatment is not always better medical treatment. And in fact, there's a fair amount of evidence that people that have higher use of doctor visits are actually more likely to end up dead or end up impaired.
Is that because they're neurotic and they think something's wrong with them?
They didn't go that far with it. This is like health services research data. So this started off with.
I'm probably using the word.
They interviewed like the original guy who did this work in like different villages in Maine, but they started off with the observation that different places with the same health profiles have really different patterns of treatment. They started off with things like the original stuff was about the rate of hysterectomies. And he noticed, I think he was working in Maine at the time, but like you have one little small town in Maine, another little small town in Maine, and this one had like 4 times as many hysterectomies as that one. And they looked at all the possible differences in health behaviors, illnesses and stuff, and nothing really seemed to explain it. And then they kind of went on to this from talking about how like the fee-for-service system sort of encourages doctors to maximize income by increasing the use of visits, and that, in fact, there's evidence that
so it was human error.
if you, I mean, basically the argument goes, sometimes people are getting treatment because it's to the financial advantage of the doctor and the hospital rather than because they need it, and if you're getting unneeded treatment, you're more likely to get, you don't get the benefit of the treatment because you didn't need the treatment. But you get the side effects because everything has side effects and downsides. And so if you're getting new medication you don't need, you're getting debilitated by the side effects of the medication. If you get surgery you don't need, you're getting all the downside of surgery without the benefit of having the surgery that you actually needed. And then there's other specific things like surgeries for back pain, or a lot of the things that are done. In fact, the outcome results are really bad. They actually finished up with an estimate that something like 30% of Medicare was being spent on treatment that probably isn't needed, and how much money you can save if you can dig into that. But first you have to convince the American people that more isn't better, which would be really hard. Deeply believe that. This is one you don't have. I went back and looked up because I wanted to get to the, well, I wanted to make a different kind. Terracciano et al. From the Baltimore longitudinal study analyses do this combination of cross-sectional data, and then the HLM lines are, HLM is hierarchical linear modeling, but the important thing to understand here is these are the solid lines, the HLM lines are the longitudinal data, and the dashed lines are cross-sectional data. And what they want to argue is that when the lines overlap, right, and go in the same direction and whatnot, you've got, you probably don't have cohort effects. And so neuroticism they've got data from like age 20 about out to 90, and they show this kind of curve. The other thing that they do that I thought was kind of cool is they look at curvilinear effects instead of trying to stick a straight line on the world. And so they get this kind of curvilinear effect of neuroticism longitudinally declining from 30 to about 70 and then kind of leveling out. Cross-sectional data shows it's going to increase, which is kind of interesting. The facet stuff is probably more detailed than we need. Extroversion, the lines are essentially identical. Agreeableness increasing and increasing both longitudinal and cross-sectional. Conscientiousness, kind of different patterns where you have kind of the same shape, but you've got kind of different trajectories with the.
Why would that mean?
They would take this as not conclusive, but prima facie evidence of cohort differences. And I forget which way they interpret it, partly because the way they interpreted it didn't make sense to me. If you cross-sectional old people are lower and the longitudinal trend is higher, which way would you go?
I just wanted to ask, how amenable are these to change? Like, if you're like, well, I need to get it together and be on time. Or, I mean, can you, consciously change?
Save that for about 15 minutes. If I don't get back to it, remind me. It's a very important question, but I don't want to lose it. But, I want to tell you about how things don't change first, and then we'll talk about voluntary issues. So what do you think? Longitudinal, you end up higher, and you peak later. So probably earlier born cohorts were relatively lower. Later born cohorts are higher.
I don't understand it well enough to.
Yeah.
Maybe the work restrictions have changed and people are more prone to getting fired if they're not there on time now. Maybe. Or a different sample.
That sounds like the wrong direction.
Oh.
It seems like things are looser now.
Yeah, they
Well, yeah,
are.
exactly. But or maybe there's something, they're playing Farmville on Facebook and they have to make sure they get it up on time.
Really, because actually in another couple of slides we have some slides where people actually analyze data by cohort. And then you've got openness, just straight downhill. Both.
Wait, that fantasy feelings, is that all part of openness? Like little aspects of, are
Yeah,
people
these are all
openness?
facets of the Neo.
Uh-huh.
So you could, if you get interested in this will be up on Blackboard soon if you want to come back to these and look at them in more detail and think it over. Each of these has facet level stuff, and you can unpack them if you get intrigued about what might be going on, at least in their study in Baltimore. Marachik and Spiro, this is a longitudinal study changes, and then they unpack them in a slide or two. Just neuroticism and extroversion, and this is the normative aging study up in the Boston area, just originally a VA-based study. So extroversion, everybody like no change over time, and extroversion, and this kind of curve. This is from 40. You don't start as early as others. And then neuroticism has this kind of curvilinear decline. And then the same stuff broken out. This is extroversion, and this is by cohort. So the earliest born cohort is over here. And so you've got not only different levels slightly, but different directions of change over time by cohort. So these are longitudinal change, but each line of longitudinal change is from a different cohort group. So you've got your earliest born around the early 20th century, you've got 1920s, and then you've got 30 to 45.